Good morning and welcome everyone to the finale of Teachers of Tomorrow. I hope you have had a great time, and there have been, I think, 2 prelim sessions and there were 110 prelims, and there were total of 110 teams, and top 7 have come up over here. Top 8 have come up here. So every team has 2 people and you have your topics already in hand. 3.5 minutes. Your PowerPoints are uploaded. Okay, so let's have a quick check. Avengers are here. Avengers, what's your name? Can you tell us your names? So Dr. Presenters. Dr. Vedant Sharma. Nishwat. Okay. So I think, mentor, you can introduce them and we can start with their presentation. You want to give a brief intro?
No, but they are the 5th team. The first team has to start. I've given the lots.
Okay,
All
you've given the
8 of them
lots.
have their lots.
Okay,
Yeah.
okay. So who has the first lot?
First lot, come forward.
Visionaries.
3.5 minutes. 3.5 minutes. 2 of them are going to be talking. And judges, you all know on what 3 points they are going to be judged. Content, speaking skills and time limit. 3.5 minutes is allotted to them. So team 1.
The visionaries. Can you please come ahead? Mentor.
The team 1, Shubha's team. Shubha Jawar's team.
You want to introduce your presenters? You want to give them a applause for their good work that they have come to the finale?
Yeah, so I'm happy that my team with Dr. Darshana Mantri and Dr. Vaishnavi Deshmukh, we are coming from GMC Chhatrapati Sambhaji Nagar, and they have reached here. I'm happy for that. Congratulations and best wishes to all the teams here. So you can go ahead. I'm Dr. Shubha Jawad. Yeah.
Can you set the time, please?
Ma'am, should I start?
Yes, please start.
I have one more.
Timer, can you please start the timer? Yes, please start.
A very good morning, my first year trainees, myself, Dr. Darshana Mantri, and I am going to teach the management of congenital glaucoma. So let's start. With a case scenario, a mother bought a child with chief complaints of a large blue eye with watering and photophobia. So, what to do next? Chalo Daya, pata lagate hain. Initial evaluation, as it was done in the last lecture, the adnexal source of irritation, lacrimal system obstruction, visual response, we all learned this in the last lecture. So, in this lecture, we'll learn the evaluation under anesthesia. The most important, corneal examination. Here we can see the enlarged cornea of size 13.5 mm. There is corneal edema, also HAPS tri. Tonometry was done. Normal was 8 mm of Hg, but our child was having 35 mm Hg. Then gonioscopy was done. We can see the trabecular dysgenesis and the iris was inserted anteriorly. Then fundus examination, there was large cup to disc ratio and nasal shifting. Then excellent was done, it was 20.5. Posterior segment, RD and the ocular tumors were ruled out. Now, after all this evaluation, we came to the diagnosis that a poor child is having congenital glaucoma. The IOP is raised and now we have to reduce this IOP. What is the management? We can do medical management like to preoperatively to clear the cornea, adjunctive modality along with the surgery or temporary. Then beta blockers or carbonic anhydrase inhibitors can be used. Surgery, it is the definitive management. In Western world, as the presentation is early, the corneas are clear, they go for goniotomy. But in India, as the presentation is delayed, the cornea is hazy when they come to us, we usually do trabeculectomy or a combined procedure. Then goniotomy, as we can see in this video, the Cope's lens is placed. We enter the anterior chamber with a 27 gauge needle, we will up and create an incision, create a pathway for aqueous to drain from the anterior chamber to the canal. Trabeculectomy, here we can see in this video, scleral flap, superior scleral flap is raised. In the deep scleral flap, we'll create an entry into the Schlem's canal, put a Ham's trabeculectome inside the canal and create an entry into the anterior chamber. Also, a pathway is created for the aqueous to drain. The second surgery, trabeculectomy, here also the superior flap was raised. In the deep flap, we'll excise a tissue of 1 by 1 mm from the deep sclera just over the angle, and also we'll do a peripheral iridotomy. Here a bypass pathway is created and aqueous is drained. Also we can use the glaucoma drainage devices like the one with valve, other one without valve. Now follow-up. Follow-up is most important. We have to counsel the parents that a long-term, a lifelong follow-up is needed. You have to bring the child every 3 to 4 months, and as the child will come to you, check the visual acuity, IOP, axial length and amblyopia. Rehabilitation. This child, the children with low vision should be rehabilitated so that they can have a good life. Also counsel the parents. Thank you. And also I'd like to say one thing. Recently I visited the APO conference in Delhi, and here I learned that a brimatoprost implant is introduced. This is in foreign countries yet. Let us keep an eye on the Indian market when it enters. Thank you.
Thank you. Can
And the second speaker.
yes, ma'am.
A very warm good morning everyone. I am Dr. Vaishnavi Deshmukh, and topic for today's class is limbal stem cell. So dear students, just imagine your eye as a ecosystem and the limbal stem cells as the gardener. They constantly repair and renew this ecosystem. So let's explore these tiny little cells. So what are limbal stem cells? These are long-lived cells. They have long cell cycle time and they proliferate but don't differentiate. And they are stimulated only after injury. So where are these located? These cells are located at palisades of Vogt. They are this highly magnified picture shows ridge-like pattern known as palisades of Vogt. This is the histopath image of the same. Superiorly and inferior part of the limbus, they are abundantly present. Now how does the division occur? It divides into two stem cells. Further on, it divides into transient amplified cells, which further transforms to post-mitotic cells, and later on into terminally differentiated cells. This whole process takes place within 7 to 10 days. Now coming to functions, they act as a barrier for conjunctivalization and maintain the normal corneal tissue homeostasis. Now let me explain you the XYZ hypothesis given by Thoft and friend. So these eggs are nothing but the limbal stem cell lying in the limbal niche. These wandering chicklets are nothing but the migrating cells, and these freely flying birds are nothing but the desquamated cells. So dear students, always remember what is created has to be replaced. So X will be replaced by Z will be replaced by X and Y. These stem cells are provided the protected microenvironment known as limbal niche. These vessels are nothing but providing nutrition, and there are no gap proteins, so the distinct intracellular network is maintained. While discussing about limbal stem cell, we shall definitely discuss about limbal stem cell deficiency. So it is nothing but the ocular surface disorder, which is because of the decrease in the population and or decrease in the function. So the normal corneal homeostasis is disturbed. So first damage occurs, the conjunctival cells invade over corneal surface, and neovascularization also occurs. Moving on to symptoms, as you can see, the patient has blurring of vision, photophobia, redness and watering, and blepharospasm. What are signs? As you can see in the first image, there is lusterless cornea, blanching of palisades of Vogt, conjunctivalization, neovascularization, and symbiofon can occur. They may present with a persistent epithelial defect. Causes are hereditary and acquired. Hereditary can be due to aniridia, and acquired, the most common cause is chemical burns. There are 3 stages. In stage 1, the 5 mm corneal surface is spared. In stage 2, that 5 mm surface is also involved. In stage 3, whole of a cornea involving nimbus is also involved. Now the diagnosis is clinical. So, but we should also confirm using fluorescence staining, impression cytology, and immunohistochemistry, confocal microscopy, ASOCT. The algorithm is depend on the laterality. If it is unilateral, go for slit. If it is bilateral, we can go for AIOS. These are the few steps depicting the procedure called slit. Thank you. For further read, do refer Dr. Sangwan's article. Thank you so much.
Thank you, Dr.
And for
Vaishnavi.
further reading of glaucoma, please refer Shield.
Who's the second team? Just 1 minute. What are your names? Huh?
In the meantime, Vaishnavi, can you tell us about the name of the staging system that you used for the stages of LSED?
Ma'am, it's international staging for the LSCD, so that I have used.
Okay. Is that the standard that is followed, or there is something else that is mentioned in Krashmar?
This is the newer one, ma'am. The staging, it's recently they came up with it.
So the next team is, name of your team is? Huh? Site Savers. Thank you. So the Site Savers teams has Najwa and Nagarogini. So the judges, please note. And the time allotted is 3.5 minutes. So you all can come. Mentor. Okay. You could just say a few words. How is this? The main events people are not here.
Teachers of tomorrow here, and I'm happy for the students of tomorrow. So they are in excellent hands. So I introduce my team. We are from Madurai Medical College, and she's Najwa Sharon and she's Nagarogini. I wish you all the best and wish all of you a very good luck.
Please don't start the timer right now. They haven't yet started. Are you ready?
Najwa is going to be talking. Nagarogini is presenting first.
Please start the timer now.
A very good morning, student. Today's my topic is on posterior polar cataract. Okay, students, what is posterior polar cataract? Okay, then we can discuss it detailing. It is a congenital cataract which is of autosomal dominant inheritance with a bilateral presentation, and myopes are at increased risk. What is the pathogenesis behind this? During embryogenesis, lens receives nourishment via an intrinsic vascular capsule called as tunica vasculosa lentis, which is supplied by the hyaloid artery. This persistence of hyaloid artery leads to the formation of mittend of dots and with the extensive formation of the posterior polar cataract. The histology behind this is it consists of dysplastic lens fibers. Why is it so important? Because of its strong adherence of the opacity to posterior capsule and 26% chances of defective PC and high rate of intraoperative PC rupture. The clinical types are stationary and progressive type. The stationary is bullseye appearance and progressive is radiating rider opacity. Here are the classifications of grading PPC, which is Schroeder's classification and Dahlsing classification. Okay, how will the patient presents with you? Because of this cataract locates near the nodal point, it mainly affects the vision. So the patient will have difficulty in reading fine points. What is the main preoperative counseling you will give for this patient, students? Good. Let's discuss in detail. Also, because of PC-REN, patient have long operative time and vitreous loss and pre-existing amblyopia in unilateral cases. So, hence, detailed preoperative evaluation should be done to differentiate PPC and posterior subcapsular cataract. Here is the last picture showing posterior polar component with a PC dehiscence. Choosing the surgical technique is very important because this posterior polar rupture during emulsification of nucleus in phaco and during nucleus expression and during removal of the posterior polar opacity. The first step is capsular axis. Here, the capsular axis should be well centered and slightly smaller than the diameter of the optic. Size should be of 5 mm. If less than 4 mm, it's difficult to prolapse the nucleus into AC, and if larger than 5 mm, may not provide adequate support for optic capture of sulcus fixated IOL in the event of post-PC rupture. Here are the surgical modifications. The AC should be kept stable and the high viscosity viscoelastic should be used throughout the surgery. Here is the surgery which is showing BSS inflow should be non-turbulent, and here is the phacoemulsification, and the hydrodissection should be avoided in this type of surgery. The inside-out hydrodelineation should be used. Rotation of nucleus should never be attempted. The inside-out hydrodelineation should be used, and epinucleus removal is by reverse flower bloom technique. First the nuclear material, followed by cortical material, and followed by posterior polar cataract. Other surgical caveats: inject viscoelastic from side port before withdrawing any fake or irrigation handpiece. Final take-home messages: should not be attempted by surgeon in early part of the learning curve. Careful preoperative evaluation, stable AC, avoid hydrodissection and nucleus rotation. Be careful during irrigation and aspiration. Detect PC rupture and early manage. Always be ready with vitrectomy procedures in case of nucleus drop. Here is your post-session test. Please scan the QR code and do it, students. Thank you.
Thank you, Nagarajni. It was a wonderful presentation. And do you want to change anything on your fluidics? Any change in your parameters would you like to highlight?
No FACO parameters. Power, then irrigation. Okay.
A very warm good morning, students. Today we will learn about the management of congenital ptosis. So by the end of the session, you will like to know all this about the management of congenital ptosis. Congenital ptosis results from the developmental dystrophy of the levator muscle. It can be simple or it can be associated with superior rectus weakness, blepharophimosis syndrome, and synkinesis like Marcus-Ginz syndrome. So why should we manage the case of congenital ptosis? If not, there is a risk of amblyopia, and there is a risk of negative psychosocial effect in the child and an abnormal head posture. So usually we does the surgery at an age of 3 to 4 years. So students, when should we intervene earlier? Yes, if there is a risk for amblyopia and ocular torticollis or head turn. So coming to the choice of surgery, if there is a risk of amblyopia, we will go for an urgent frontalis sling. If not, if the levator function is good and ptosis is mild, we'll go for a fascicular CERVIT. If the levator function is more than 4 mm, we'll go for a levator resection. And if the levator function is less than 4 mm, we'll go for a frontalis sling. So coming to the fascicular CERVIT procedure, it's a tarsoconjunctival mullal resection done in case of mild congenital ptosis with a levator function of more than 10 mm. So coming to the surgical technique, first the center of the pupillary axis is marked and 3 sutures are taken in the tarsal fold and 3 in the superior fornix. And tarsoconjunctival mullal resection is done and the wound is closed. Coming to the levator resection, it is done in case of moderate levator function when it is more than 4 mm. So coming to the surgical technique, see the incision is marked and we will do an orbicularis resection and a suborbicularis resection. The lid is double everted and then 3 sutures are taken on the levator and the levator is dissected. Now you can see the orbital septum. It is resected and then 3 sutures are taken in the levator and it is resected. And you can see that the distal part of the levator is removed and the wound is closed. Coming to the frontalis sling surgery, it is done in case of severe ptosis with a levator function of less than 4 mm. Different types of materials are used like the silicone sling. Coming to the surgical technique, the incision is marked as in the pentagonal shape and you can see the incision is made and then the needle and the suture and the silicone sling is passed in a pentagonal fashion and the silicone sleeve is applied and then the wound is closed. So there are different modifications of frontalis sling surgery available. Students, what are the complications of ptosis correction? It will result in corneal exposure, foreign body reaction, wound infection and lag of thalamus. So suppose if the patient is not willing or not fit for the surgery, what is the option? Yes, we can use scratch glasses. So the take-home message is, if the ptosis is mild and levator function is more than 10, you can go for fascicular CERVIT. And if the levator function is more than 4, you can go for levator resection. And if it is less than 4, you can go for frontalis sling surgery. Students, now you can scan this QR code. Yes, I can see that most of you have scored 100%. Well done, students. Thank you.
Very well presented. So thank you, presenters. Can we have the third team?
Thank you.
Third team, Mentor, would you like to say something? And then we can go to the presentations.
Good morning to all. We are the Southern Stallions. I'm Dr. Natasha Radhakrishnan, the mentor, and my mentees are Dr. Matthew Shaji and Dr. Eliza Paul. Dr. Matthew Shaji is from Travancore Medicity and Dr. Eliza Paul is from Gokulam Medical College, and the only common factor between the three of us are we are from Kerala. Matthew, please. starting with Dr. Eliza.
Good morning, friends.
Can we have the timer, please? This is not the presenter. This one?
Yes, ma'am.
Okay. Please start the timer.
Good morning, friends. Our topic for today is abducens nerve palsy. This is Alfred, my friend, who will be helping me with the demonstration. Abducens nerve supplies the lateral rectus muscle. It also helps in the coordinated lateral coordinated movement of both eyes. As you can see, Alfred is looking to the left. Now he is looking to the right. So this is done with the help of medial longitudinal fasciculus. Further, now you can see Alfred is having a right eye esotropia in his primary gaze. This is a characteristic feature of abducens nerve palsy. He also experiences horizontal diplopia. Let's see how he corrects it. Yes, by shifting his head to the right. Further, moving on to the anatomy and course of abducens nerve. First part is the nuclear part. Abducens nerve nucleus lies in the dorsal pons anterior to the fourth ventricle and lateral to the medial longitudinal fasciculus. Facial nerve forms a loop around the abducens nerve and forms the facial follicle. You have to remember that isolated sixth nerve palsy can never be of nuclear origin. Further, moving on to the fascicular part. It is basically from the pons to the pontomedullary junction. There are a number of syndromes associated with, which is Millard-Gobler syndrome, Raymond syndrome, Fowell syndrome. Further, moving on is the intracranial part. Yes, it is from this, after exiting from the pontomedullary junction, the nerve passes to the subarachnoid space, it travels above and along the clivus and enters the Dorello canal. Here, due to raised intracranial tension, the brainstem is pushed downward. This in turn leads to stretching of the nerves. Further, moving on, the nerve passes along the cavernous sinus body. Here, it is in close relation with cranial nerve 3, 4 and 5. Here we get a lot of symptoms clustered together as cavernous sinus syndrome. Further, moving on, the nerve enters the orbital part after passing through superior orbital fissure. Here we get superior orbital apex syndrome. So, homework for today is you have to differentiate between superior orbital fissure syndrome and orbital apex syndrome. Later, the nerve terminates by supplying lateral rectus muscle. Let's move on to the examination part. Age is a very important factor. If your patient is less than 50 years of age, he must be sent for complete neurological evaluation. Ask for the characteristics of diplopia, if there is any associated symptoms, history of trauma or any systemic illnesses. This helps in localizing the lesion. Further, on the ocular front, you have to do a complete squint evaluation, which include diplopia, Hess's charting, force reduction and force generation test. In the charts given to you, you can see there is lateral rectus restriction in the right eye. Further investigations include MRI, CT, blood investigation and also CSF analysis. So moving on to the treatment part. First, the most important thing is treat the primary cause. Further, in the diplopia management, you can see Alfred is wearing Fresnel prism glass and also eye patches. Bottle injection toxin can be given to the medial rectus muscle. We have to wait for about 6 months to move on to the surgical management. In surgical part, there is for incomplete paralysis of the abducens nerve, recession and recession on the horizontal muscle is preferred, whereas for the complete paralysis, vertical rectus muscle transposition is preferred. So these are the differentials. I hope all of you are smiling like Alfred after my class. Thank you.
Thank you so much. Can we have the next presenter?
Okay. Good morning all. My topic for today is corneal eye drops management. So this is Mr. Raju. You can see he's having redness in his eyes and he's a known case of keratoconus. He gives me a call and says, "Doctor, I've lost my vision in my left eye. I'm getting pain, photophobia, and I'm having some white color lesion in my eye surrounded by redness." So let's see what this is. So what is corneal eye drops? It is basically a sudden split in decimens as well as Duas layer, resulting in an ingress of aqueous within the corneal stroma, leading to corneal edema. So this is a normal corneal structure. Let's see what happens in corneal eye drops. You see a break in the decimens as well as the Duas layer. Now what are the etiology? Primary corneal ectasia like keratoconus, pellucid marginal degeneration and keratoglobus, of which keratoconus is very common. However, the incidence is only 3%. The secondary corneal ectasias are basically the surgical procedures. Now coming to risk factors. They are atopic disease, eye rubbing, young age, Down syndrome and contact lens use. What is the grading? Grade 1 is basically corneal eye drops of within 3 millimeter diameter. Grade 2 is between 3 and 5, and grade 3 is more than 5 millimeters. Now coming to the investigations. Most often we use anterior segment OCT as well as a UBM because they help in identifying the lesion as well also you can monitor the progress of the lesion. Now coming to the management. First is the medical or the conservative management. Here basically we are just treating the symptoms. So if patient has pain, photophobia, you give cycloplegics, NSAIDs, lubricants, dark glasses and bandage contact lenses. For decreasing the stromal edema, you give hypertonic saline as well as anti-glaucoma medications. To avoid secondary bacterial infections, you give an antibiotic. And to decrease inflammation as well as to prevent corneal neovascularization, you give corticosteroids. Now moving on to the surgical management. So first we have pneumatic decimetopexy. Here you give intracameral injection of air, 20% SF6 and 14% C3F8, of which C3F8 is preferred for its longer duration. This forms a barrier to prevent aqueous from passing into the stroma. Complications are pupillary block and cataract. However, in inferior DM tests, you can't do this procedure. Now coming to compression sutures. These are basically full thickness or partial thickness sutures which are placed perpendicular to the decimental tears. However, in pellucid marginal degeneration, you give a radial suturing. Now coming to thermokeratoplasty. Here using heat on the cornea so as to induce a collagen contraction. If none of these are working and responsive to gas, you use your own plasma and inject it intracamerally. Now coming to the partial surgical management, that is decimen stripping, DSEC, DMEC. Here you are changing the posterior stroma, DM as well as the endothelium. Whereas in DMEC, you are just changing the deciment membrane as well as the endothelium. Now coming to the last stages, that is the DALC as well as the PKP. In DALC, you are changing the full thickness stromal replacement. However, in penetrating keratoplasty, you do the full thickness. This is the algorithm used. So in conclusion, they are corneal ectatic disorders which rupture the decimens as well as the Duas layer. Thank you.
Warriors, Master Blasters. Who are the two?
Can we have the mentor, please?
Mentor and the team players' names.
Okay, so the presenter, can you please come up?
And give your names.
What's your name?
Gaza.
And the second one is Megha.
Hello? Hello? Good morning, class. I think with that I check off my checklist, which I ever wanted to do as a teacher. Now imagine seeing the world like this. A patient comes to you with the hope of light and better sight after his cataract surgery, but instead comes with a barrage of complaints and severe discomfort after his cataract surgery. You worried and confused. You note how every layer of cornea bears the brunt of surgery due to pseudophakic bullous keratopathy. As you document your findings, you ponder over the Hippocratic oath where you vowed, primum non nocere, the Latin phrase for first, do no harm. Hence, we retrace to how PBK may have been prevented in the first place. A history of pro-inflammatory systemic diseases, corneal decompensation in the other eye, or prior surgery or trauma in the same eye, clinical findings suggestive of corneal decompensation are important clinical cues and warrant a specular microscopy for a baseline endothelial cell count. Intraoperatively, steps to protect the endothelium by using methods like soft shell technique can be helpful, and cases with decentered IOL or ACIOL with continuous corneal endothelial insult require special post-operative care. A trial of medical management must be given in the form of topical medications and BCL before resorting to keratoplasty and other measures to alleviate pain. Evaporation of tear film is minimal at night with eyes closed. Corneal edema tends to be worse in the morning. Hence, 5% sodium chloride ointment should be applied at night as it creates a hypertonic tear film drawing water out of cornea. Topical NSAIDs and steroids help control surface inflammation and promote better healing. IOP control can decrease corneal edema and thickness in post-operative settings even if IOP is normal. Beta blockers and agonists are first-line agents for this purpose, as prostaglandin analogs and myotics can further cause inflammation, and topical carbonic anhydrase inhibitors can cause endothelial toxicity in compromised corneas. Lubricants act as a protective precorneal layer and mask surface irregularity. In case there is no improvement with medical management, we must consider keratoplasty. Please focus on the watermelon in front of you. Penetrating keratoplasty can be full thickness wherein the entire corneal graft is replaced. From the epithelium, that is the green skin of the watermelon, to the endothelial layer, that is the last edge of the red juicy part of the watermelon. Or partial thickness wherein anterior lamellar keratoplasty implies replacing the anterior layers of the cornea including epithelium, Bowman's and stromal layer. Or posterior lamellar keratoplasty, which implies replacing the posterior stromal layer, desmids and endothelial layer. A rhexis of the posterior corneal surface using a reverse cystotome removes the damaged posterior corneal layers from the endothelium up to the posterior stroma. DSEC includes replacing a layer of the posterior stroma, desmids and endothelial layer. DMEC includes replacement of desmids membrane and endothelium, and DWEC includes replacement of just the endothelial layer. Post-operatively, a close watch is important to observe for a healthy graft-host junction and well-opposed endothelial graft for gratifying results with significant clinical improvement. AIOS2025 is an important tool to check graft-host junction and graft placement post-operatively. Endothelial keratoplasty is standard of care for PBK for faster visual recovery with lower astigmatism as compared to full-thickness penetrating keratoplasty with a significantly lower risk of graft rejection and post-operative glaucoma. Even though DMEC is superior to DSEC in terms of rapid and better visual recovery with no stromal haze, minimal hyperopic shift and lesser chances of graft rejection, it entails a higher risk of graft dislocation and has a much longer learning curve, making DSEC the popular choice. In patients where visual prognosis is guarded, meticulous starting can and alleviation of pain can be done with these methods, and we can restore right to sight and a life of light with our patients. Thank you.
Thank you, Megha. Can we have the next presentation? Can you please start the timer?
For centuries, retinoblastoma was a silent thief robbing children of vision and life. But today, we fight back with precision, innovation and technology. I'm Dr. Farnaz and I'll show you what's new in retinoblastoma. From a time when survival was just a mere hope, to the future where vision can be saved, it has always been a medical thriller. From 85 to 90% mortality, enucleation for all, EBRT to intravenous chemotherapy and to the current trends. But the hierarchy of goals is very clear: life salvage followed by eye salvage and then vision salvage. If the tumor won't come to the chemo has to go to the tumor, right? And trust me, we have found every possible way to sneak the drugs in so many routes as you see on your screen. Intravenous chemotherapy can be neoadjuvant, where chemo reduction is required, adjuvant post-enucleation, and high dose for orbital retinoblastoma, but the problem being poor systemic tolerance. So intraarterial chemotherapy is the new. It could be primary, secondary, tandem and bilateral, bridge or rescue based on the indication. The three main drugs used are topotecan, carboplatin and melphalan. So let me demonstrate. So here we have The catheter, when passed through the femoral artery, say the right eye, goes to the ophthalmic artery, and thereby we inject 3 drugs via the stent, and followed by that you will have to see how beautifully the tumor shrinks after 3 cycles of your IAC. Alright. So, what's the problem now? We still have vitreous seeds. So, how do we tackle it? Yes, intravitreal chemotherapy. That comes for the rescue. So 3 drugs usually were used earlier, but now we have come down to topotecan because it has better bioavailability and also minimal retinal injections are required. So the stepladder pattern shows the evolution of intravitreal chemotherapy. So this, when injected in high dose, will lead to resolution of all the vitreous seeds and clumps. So this was established by this study as well. On your screen, look at the excellent resolution of all the vitreous seeds just with 3 injections. Focal therapy is mostly ice and fire. Freeze the tumor with cryo, or which might lead to a heat scar, or burn it with laser, which will lead to ILM rupture and vitreous seeds. TTT acts like a sniper, and thereby we have all the ICG enhanced TTT, which is the modern one, that can also lead to all the area which is scarred as well, and thereby ultimately laser uptake. We already know plaque brachytherapy, right? But sustained topotecan episcleral plaque is the new in this. And this is the novel drug delivery system, not just in glaucoma but also in retinoblastoma. And the latest gene therapy still under exploration. So the trends have changed from just saving lives. We have moved to saving eyes and vision as well. So welcome to an era where we don't just fight cancer, we fight for the quality of life with an evolution of treatments like in no other cancers. Thanks a lot.
Can we have the names of the participants? Mentor. You are the mentor?
Yes, ma'am.
And your speakers are?
Such a young mentor.
Dr. Vedant and Dr. Nishwat. A very good morning to one and all, my fellow colleagues and all the respected judges. So I'm Dr. Sameer Chaudhary, and my mentees are Dr. Vedant Sharma and Dr. Nishwat. We are Team Eye Avengers from Arvind Eye Hospital, Madurai. And I have been on this stage 2 years ago as a mentee. I was one of the finalists, and I believe this is a very, very great initiative as it brings out, it drives away the stage fright and also improves your presentation skills very drastically. So all the best to all the teams, and just enjoy the process. Thank you.
Can we have the presentation, please?
The human body was never designed for a sedentary lifestyle. It was created to hunt saber-toothed tigers and walk 40 miles a day. India is the diabetic capital of the world, where the prevalence stands at almost 8.9%, and it is only expected to get worse. It is expected to double by the year 2045. Diabetes has its systemic manifestations in microangiopathy and macroangiopathic effects. However, the one which is most relevant to us is the diabetic retinopathy. Most common cause of vision loss in patients of diabetic retinopathy is diabetic macular edema. Good morning to one and all. I am Dr. Vedant Sharma, and I am from the Team Eye Avengers, and today we are going to present the management of the management of CSME, clinically significant macular edema. Edema means increased thickness, and early treatment diabetic retinopathy study defines CSME under 3 different headings: thickening at or within 500 microns from the center of the macula, hard exudates at or within 500 microns from the center of the macula, thickening of 1 disc area or larger if within 1 disc diameter from the center of the macula. However, clinically speaking, it is crucial to us to determine whether it is center involving or it is non-center involving diabetic macular edema. The pathogenesis all begins with the high glycemic environment causing interplay of various mediators, causing loss of pericytes and disturbance of inner blood retinal barrier. The management can never be one. It has to be both systemic and ocular in nature, where the systemic management is the most crucial about the glycemic control, which has already been documented in the DCCT study. Hypertension, lipid control, and anemia all play significant role in the control of diabetic macular edema. The ocular management, however, is the most crucial to all of us. The gold standard treatment for the ocular management of diabetic macular edema are the anti-VEGF therapy, where the anti-VEGFs directly either neutralize the VEGFs or themselves attach to the receptors, preventing the VEGFs in turn to attach themselves to the receptors, indirectly inhibiting the signaling pathway and dismantling the angiogenesis. They are marketed under many brands, just like aflibercept, ranibizumab, brolucizumab, bevacizumab, and faricimab. Intraocular steroids like intravitreal triamcinolone, intravitreal implants are of great use, in which intravitreal triamcinolone has been documented in pseudophakic patients and in refractory DME, as seen in this case, where it worked like a magic. Intravitreal implants, which are slow release like Ozurdex and Illuvin, have been used in recalcitrant DME cases, and also, but the main side effect with them is they do cause higher rate of cataract and ocular hypertension. The laser photocoagulation are of immense use. However, grid laser and focal laser had been advocated in the past, but presently micropulse subthreshold is the treatment of the laser, where it causes no anatomical damage and causes stimulation of retinal pigment epithelium. Trials such as Protocol A, I, TU, MEAD study and FAME trial have all been advocated regarding the usage of anti-VEGF therapy and lasers in patients of diabetic macular edema. In the end, I would just like to say that retina is a canvas of light where the surgeon's art paints the patient's view. Thank you so much.
Very good morning, respected juries. Even the largest avalanche is triggered by small things. So what is the small thing? Small thing refers to the small eyeball, which triggers an avalanche of complications. Yes, the topic of discussion for today is nanophthalmos. The normal eye has an axial length of 22 to 24 millimeter. So what is nanophthalmos? Nanophthalmos is an eye that is normal in shape but smaller in size with an axial length of less than 20 millimeter. It leads to very high axial hyperopia, but it has a normal sized lens. How does nanophthalmos occur? It can occur de novo to anyone, you, me. Basically, it is sporadic in nature, or it could be autosomal dominant or autosomal recessive. Nanophthalmos is a bilateral condition without any sex predilection. How is nanophthalmos different from microphthalmos? Nanophthalmos is a type of microphthalmos. Basically, it is simple microphthalmos without any anatomical malformations. In microphthalmos, there is generalized minification, including the crystalline lens. So why are we even worried about nanophthalmos? It is because of the thick sclera. It can lead to spontaneous choroidal effusions by blocking of the vortex veins. Ciliary body moves anteriorly, displacing the peripheral iris, leading to loosening of the zonules, moving the lens forward, which leads to angle closure glaucomas. You can see a normal eye compared to that of an nanophthalmic eye. The lens occupies relatively a larger volume of the eyeball. There is thickened sclera which can cause spontaneous effusions. So what to do in case of progressive angle narrowing? YAG laser peripheral iridotomy is the treatment of choice. It can be combined with anti-glaucoma medications, and even laser gonioplasty can be considered. So what are the surgical considerations in a nanophthalmic patient? Surgery should be avoided unless it is absolutely necessary because of the risk of choroidal effusions, retinal detachment, flat anterior chamber and cataract formations. So it is better to use an intraoperative anterior chamber maintainer. Prophylactic sclerotomies can be considered. Even pre-op, hyperosmotic agents like mannitol and glycerol can be used. Coming to the pediatric considerations in case of nanophthalmos. Hypermetropia is the concern for us. So spectacles should be given as early as possible with complete cycloplegic refraction. Accommodative insufficiency, if it is there, bifocals or even progressive glasses can be considered. So friends, small things become great when done with love. So always treat your nanophthalmic patient with caution and care, and more importantly, with love. Thank you.
What is the next team is? Spectacular. Spectacular. Who are the two players? What's your name? Koil. Huh. No, names I want. Koil. Huh?
Koil.
Arandash.
नाम ऐड कर लीजिए आनंदास
Aran.
हाँ डॉक्टर नाम बताइए
And you are Koil Verma. Burman. Okay.
वापस पे आ।
So, can we start?
Oh, yes, ma'am.
Yeah.
So, good morning, class. Today, very important topic. So, kindly don't close your eyes because the topic is BPS, the eyes white shirt. So, the clinical spectrum of the BPS, there's a 4 spectrum, the blepharophimosis, ptosis, epicanthus inversus and telecanthus, and associations are ectropion, strabismus, high arched brows and looped ears. And these are the 3 questions please kept in your mind whether this is true or false. So first component is the blepharophimosis, and it refers to the horizontal shortening of the palpebral fissure, normal the 25 to 30 millimeter, but in the BPS this is short 20 to 22 millimeter. Second is the ptosis, and this is the upper eyelid drooping which resulting in narrowing of fissure height. This involves the dysplasia of the LPS muscle and which resulting in the poor LPS muscle and the bilateral ptosis. So test to check for the LPS, this is a Barkes method. And epicanthus inversus, this is a type of epicanthal fold which is originates from the lower eyelid and curves upwards towards the inner corner of the eye and covers the medial canthus. This is my graphical presentation. Lastly, this is the telecanthus, and the increased distance between the 2 medial canthae must be differentiated from the hypertelorism. So, what is the etiology? This is a genetic syndrome, autosomal dominant inheritance fashion, and which is the de novo mutation in a FOXL2 gene. So, this is my pedigree chart, and FOXL2 gene which 72% cases shows mutation, and this leads to the various BPS phenotype which leads to the BPS subtype and which had a clinical significance. So first of all, there are 2 types of BPS, BPS 1 and 2. In BPS 1, this is a frame shift nonsense mutation, but in BPS 2, there is a missense mutation which means partial function. So in BPS 1, there is an association premature ovarian failure with eyelid abnormality, infertility and hormonal instability present, but in BPS 2, no hormonal instability. So, at first all, whenever a BPS patient comes to us, first of all, history taking is very important. Family history, use my pedigree chart, ocular history, whether amblyopia or how much visual acuity, and systemic history, there is a infertility or menstrual history present or not. So, clinical examination, ophthalmic examination, there is a measurement of the palpebral fissure height, quantification of the ptosis assay and the lid assessment, and there is a systemic evaluation, hormonal evaluation in case of females. So, indications for surgery in the BPS, there is a functional indication, cosmetic and psychosocial indication. Functional, there is a severe ptosis causing the visual obstruction. So, this is the surgical planning for eyelid correction in case of childhood, canthoplasty done, in case of school going age, ptosis surgery and eyelid refinement surgery. If there is a more telecanthus, there is a 2 parts, and after that 6 months, ptosis correction. If there is a less telecanthus, so sling surgery first. In case of scenario 1, whenever the patient comes to us in her current condition, and we must concern about the keloid formation. So this case, we must not do any surgery. And in case of scenario 2, if she is not bothered about the cosmesis, so we must try do surgery. And this is the surgical steps. And first of all, jet flaps cut and skin and superficial tissue exposed, medial palpebral ligament sutured with the transnasal wiring. And this is the post-operative outcome, and this is my take-home message, and this is the homework for today's class. Thank you.
Next presenter, please.
Okay, so good morning class. I am Dr. Arhan Das Gupta, your full-time storyteller, and I am here to tell you a very interesting story. One fine morning when I was seeing patients in my OPD, my student came running to me saying, "Doctor, there's a celebrity in the OPD." A celebrity in my OPD? And what has she presented with? She says that her world has split into two. And what difficulty does that cause? That can be a cause of discussion. Now, before moving into conclusions, let's take a good clinical history. My students attended Eliza Madam's class and they're very proficient with taking a history in this case. They said that the visual acuity in this case was 6/6, but there was acute onset bilateral esotropia in primary gaze which worsens on lateral gaze. Anezo deviation in primary gaze? Well, check a few things here. Does the extent of deviation vary with extraocular movement? Does there any refraction or accommodation affect it? And what is the condition of the fundus? Well, diplopia in this case is constant in all gazes, said my students. And there is no abnormality detected in the refraction or accommodation, even though there was systemic rise in the BP. The disc margins were blurred, and on checking documents it was noted that a force duction test and active force generation tests were done elsewhere, and there was certainly no abnormality. So my dear students, I asked, what do you think is not functioning? It was a case of acute bilateral esodiviation due to sixth nerve palsy with blurring of vision, blurring of the disc margins, that is papilledema. My student exclaimed, cranial nerves and papilledema, there must be something in your optic canal. My dear student, how can you say such a thing after Eliza Madam's class? You must understand the anatomy well.
Cranial nerve and
the sixth nerve passes first from the nucleus in pons, moves around the fascicles, then goes to the clivus in through the Dorello's canal, and then to the superior orbital fissure in order to enter the orbit. And the lateral rectus muscle, if not functioning, will move your eye medially, causing the squint. Cases of bilateral LR palsy can always present with these causes, so you can easily remove the unilateral causes. Well, is it then because of meningitis or ischemia? One said, okay, how can this person present coming walking to your OPD with no neck rigidity if it's meningitis or ischemia? Get a few investigations done. An MRI brain with orbit and angiogram? What are you saying, sir? It's a palsied cranial nerve and you talk of the brain? Well, that is what a false localizing sign is. Send him to a neurologist and he'll get a head elevation with osmotic agents, and he will rule out the presence of IIH or TTH, which are the major causes. He said, sir, aisa thodi hota hai. He has come with bigger problems. So we need bigger solutions in this case, and that is what the role of an ophthalmologist is in acute phase, to administer Fresnel prisms, occlusion and contact lens to occlude. And if there is no resolution, then we must go up for surgery. And since my students had again attended Eliza Madam's classes, they knew what surgeries are and they could easily answer my questions. I just told them two take-home messages. Only if it's a congenital LR palsy, look for chances of amblyopia as well. And after a lot of brainstorming, always use my algorithm to figure out such cases. Thank you.
Can we have the next team, please?
The next team is Visionaries by Sashi Agarwal.
The timer has started. Okay, good morning class. Let me wake you up with a case that presented to me in the OPD in morning. This is a 33-year-old male patient, came with chief complaints of gradual blackish painless protrusion in the left eye since 2 years. She sustained a blunt trauma in left eye 2 years prior to this. There was no immediate medical treatment taken. There was progressive bulging without pain and there was no vision preservation. The visual acuity was no light perception in the left eye. Large anteriorly protruding blackish scleral mass with thin walls at the ciliary zone was present. The cornea was clear, chamber was deep and pupil was peaked towards the mass. There was normal right eye examination. Then what did I do? B-scan ultrasonography was performed and it confirmed a large ciliary staphyloma with thin ectatic sclera. The CT was done to rule out any presence of intraocular foreign body or any intraocular mass. So, now that you've come to know the topic of my discussion, today is anterior staphyloma. Let me brief it down for you. What is anterior staphyloma? It is a localizing or protrusion of weakened cornea or sclera, usually caused by thinning and structural damage, which results in underlying uveal tissue becoming visible. What is the etiopathogenesis of this condition? It will begin with a primary injury, which could be trauma, severe infection like keratitis, corneal ulceration, could be fungal, bacterial or viral, inflammatory conditions like scleritis or keratoconjunctivitis, which will lead to tissue destructions by inflammatory mediators, or enzymatic degradation by matrix metalloproteinases, which will lead to further thinning and weakening of the cornea or sclera. By the virtue of intraocular pressure, the uveal tissue is pushed towards the weakened area. Further, in chronic cases, it could lead to scar formation, which will be a weak scar. What are the types of anterior staphyloma? It could be a corneal, it could be an intercalary one, or it could be a ciliary staphyloma. Cornea will be localized in the corneal region, which could be due to severe keratitis or trauma. Intercalary could be in the limbal area adjacent to the cornea, which would be associated with scleritis or surgical trauma history, or a ciliary staphyloma, which could be due to scleritis or glaucoma. Now, how will we examine this case? Particularly in terms of history taking, we must take special attention to the past medical and ocular history pertaining to trauma, infection and surgery, and systemic history pertaining to autoimmune diseases. How will I will examine the case? To check for protrusion of or bulge in the eye, blade closure, possible exposure keratopathy, scarring and vascularization. On slit lamp examination, the anterior segment should be carefully evaluated for corneal thinning, pigmented bulge, uveal tissue, scarring, corneal clarity. Tonometry and fundus examination should be performed, and these special investigations like B-scan, AIOS2025 and ultrabiomicroscopy will also help me in management of the case. Additional testing of microbiological culture and sensitivity and autoimmune should be performed. Now, what are my differentials? It could be corneal ectasias, but you could clearly differentiate from the clear cornea without dark pigmented exposure. It could be corneal ulceration with perforation. There will be history of infection and presence of severe inflammation. You could differentiate from anterior segment dysgenesis. It will be present from birth. And other ocular anomalies. Post-traumatic iris prolapse should also be evaluated with clear history of trauma or surgery. Microphthalmia with keratopathy might also mimic the condition. It will be associated with other congenital anomalies, or with systemic involvement. It could be a scleromalacia perforans, which will be painless and there will be no inflammation. How will I manage this case? The management clearly depends on visual status, the site and extent of staphyloma. It could be managed medically in milder cases or as supportive treatment for prevention or for preparation of surgical intervention. Surgically, if it's a corneal involvement, we could do therapeutic keratoplasty. If it's scleral involving sclera, we could do scleral patch grafting. And in painful blind eyes and severe inflammation with no visual potential, we have to go for evisceration and enucleation along with cosmetic rehabilitation. So, to conclude, collaborative care with cornea, glaucoma and oculoplasty is required for optimal outcomes, and patient's condition, visual prognosis and cosmetic needs should be considered. Thank you.
What's your name?
Honey.
Very good morning to all, and welcome to my session where we will be discussing the management of fungal keratitis. Now first we will discuss about the investigations that has to be done. Corneal scrapings should be taken from the ulcerous edge and the base. Corneal scrapings should be taken with spatula or a surgical blade. In case this cannot be done, anterior chamber tap and corneal biopsy is also advised. In the investigations, we can either go for direct microscopy. For supplementation, we can even go for fungal cultures, polymerase chain reaction, confocal microscopy and biopsy. These are the few examples: KOH wet mount, gram stain, which helps in identifying the coexisting bacterial infection in case of fungal keratitis. This is Giemsa staining, lactophenol cotton blue, calcoflower white stain. Fungal culture helps in identifying the culture sensitivity as well. Polymerase chain reaction helps in identifying the fungus accurately, confocal microscopy and the biopsy. Now in treatment modalities, we can either go for medical treatment, and in case it doesn't work, we have to go for the surgical treatment as well. In medical treatment, we first go for topical antifungals, which includes empirical therapy of natamycin 5% suspension. In case it doesn't work, then we'll have to go for systemic antifungals, which includes intravenous amphotericin B and oral antifungals like the azoles. In surgical treatment, we can go for superficial keratectomy, anterior chamber wash, intracameral or intrastromal injections, corneal collagen cross-linking, conjunctival grafts, tarsorrhaphy, and if it doesn't work, we'll have to go for therapeutic keratoplasty. Now, in addition to this, the patient has to be treated symptomatically as well with supplemental treatment in the form of antibiotics, cycloplegics, anti-glaucoma treatment, or bandage contact lenses in some cases. Now, the specific topical drugs, apart from topical 5% natamycin suspension, could be topical amphotericin B in the concentration of 0.15% for Candida and Aspergillus. And in resistant cases, we can also supplement it with topical 1% voriconazole. I might add that voriconazole and posaconazole are excellent intraocular penetration, and they provide a broad coverage. The surgical treatments include intrastromal injection of amphotericin B and voriconazole. It can also include intracameral antifungal, that is amphotericin B in 5% dextrose in cases of intraocular extensions. We can also go for surgical treatment like collagen cross-linking, that is a photoactivated chromophore for keratitis, corneal cross-linking, which helps in the increased resistance of the cornea against digestion. The surgical treatment, miscellaneous ones, are conjunctival grafts, that is a Gunderson flap. We can also go for tarsorrhaphies, which provides a healthy environment for the keratitis to heal. In case it doesn't heal, we finally have to go for penetrating or lamellar keratoplasty. This is a summary for my management. That is, first we will start with the medical treatment, that is natamycin 5%. If the patient responds, we'll go for a follow-up. If the patient doesn't respond, we can go for culture sensitivity, and if the reports come for a particular antifungal, we'll start with that. In case of resistant, we can go for voriconazole. In surgical treatments, we can either go for intrastromal or intracameral injections. If it doesn't respond, we can finally go for therapeutic keratoplasty. Thank you.
The speakers' names? Smriti, Soni and?
So good morning everyone. I am here to introduce my dynamic team JEDIs. I am Dr. Saitya Bhaskaran. I am mentoring Dr. Priyadarshini and Dr. Smriti Soni, and we are from Arvind Eye Hospital, Madurai. All the best to all teams and congratulations to all teams for having made it here.
Good morning everyone. Imagine if you are sitting in an operating table, getting complications like PCR, what do you get up in your eyes? Is it anger? It's tears, right? Come, let us learn about tear film. Tear film is a thin, multi-layered fluid structure which covers the cornea and conjunctiva. Its main function is not only to provide ocular lubrication, but it also serves several critical functions beyond maintaining lubrication, which involves preserving the corneal epithelial integrity and also maintaining the optical refraction. The layers of the tear film include outermost lipid layer and the middle aqueous layer and the innermost mucin layer. The lipid layer is composed of lipids which are secreted by the meibomian glands. Its main function is to prevent aqueous layer evaporation and also to prevent the tear spillover. The aqueous layer is composed of water, electrolytes and proteins which are secreted by the lacrimal glands, and its main function is to provide oxygen and nutrients to the corneal surface. The mucin layer is composed of mucin glycoproteins which are secreted by the conjunctival goblet cells, and its main function is to smoothen out the corneal surface. Now, what happens if any of these layers such as lipid, aqueous or mucin layers are absent? Come, let's see. The deficiency of the lipid layer results in rapid evaporation of the tears, resulting in evaporative dry eye, leading to meibomian gland dysfunction. The aqueous layer deficiency results in inefficient moisture on the ocular surface, resulting in aqueous deficient dry eye, leading to epithelial damage and ulceration. Then, the mucin layer deficiency, it results in corneal abrasion. After all these things, aren't you guys curious about learning your tear film status? You're curious, right? Come, let us learn about the test for tear film. Now, to test the tear film stability, tear film breakup time is done where the dry spots after a blink is calculated, and the diagnostic test, it involves measuring the tear production, where Schirmer's test is done, which involves placing a tear strip at the junction of medial 2/3 and lateral 1/3 of the lower lid, and after 5 minutes the strip is then removed and the amount of wettability is then noted. And the amount of wettability more than 15 millimeter indicates that it is normal. And in tear osmolarity test, the concentration of the dissolved solutes in tears, it is measured. And the value is higher than the normal value, it indicates that there is a dry eye. And to visualize the structures in the meibomian gland imaging such as meibomiography can be done. Here, the first picture shows a normal meibomian gland seen on meibomiography. The second picture shows a focal meibomian gland dropout. And the third picture shows a diffuse meibomian gland dropout seen in case of severe meibomian gland disease. The recent advances include measuring the biomarkers in tears, nanotechnology for targeted drug therapy, contact lenses which can either be diagnostic or therapeutic, gene therapy, regenerative medicine in the tear film, and ocular surface microbiome, and wearable technology as seen in the picture. It can either be contact lens based, spectacle based or eye patch based. Now, tomorrow, if anyone comes and asks you about tear film, tell them with these mnemonic: lemon for lipid layer, alarm for aqueous layer, and MG for mucin layer. Since we have learnt about the importance of tear film, hope you don't lose your tears unnecessarily. It's precious. Thank you. Your name? Priyadarshini. Thank you.
My name
Good morning, everyone. Are you all ready to deal with RD? Let's go. Let's go. So let me bring to you a scenario where there are two boxing legends, Mike Tyson and Muhammad Ali, getting in a face-off with a double knockout. And then they come to your OPD presenting with a couple of symptoms. Mike Tyson comes to you saying that he's seeing multiple flashes, floaters, and blurring of vision, and he's having multiple complaints. What about Muhammad Ali? He has a sudden loss of vision. Then I take up my armamentarium and I take out my indirect ophthalmoscope. And as a result, I see, when I go to Mike Tyson's eye and I look into his retina, I can see a horseshoe tear in a particular corner of the fundus. And as I evaluate his lesions, I can see a convex configuration with a loss of choroidal pattern and subretinal fluid that extends all the way to the ora serrata. So what am I talking about? Fresh retinal detachment. And then when I evaluate Muhammad Ali's fundus, I do not see any fundus reflex. So I can't just stand there. I should go for the B scan. And when I open my B scan, I can see a hyperechogenic lesion. And that's when I understood that there was a retinal detachment which was masked by a vitreous hemorrhage. So you all know what a retinal detachment is. It is the separation of the neurosensory retina from the underlying RPE. So we can't just stand and watch. We need to take up our instruments and get on with the surgery. So before we move in, we need to remember three things. First, we need to identify all the retinal breaks, as it is imperative, as it's the most common cause of all failed surgeries. How do we go about this? By using the Linkoff's rules. Secondly, we need to ensure that there is adequate chorioretinal adhesion and also ensure that we seal the break tight. So let's operate on Mike Tyson. As we could see his lesion, why not go ahead with scleral buckling? So what are the indications with scleral buckling? We should check whether it has any indentable posterior margins, whether he's a young phakic patient, and in his case was there trauma, and leading to that was a secondary retinal dialysis. What are the principles we need to ensure? We need to see that we can identify all the breaks, seal all the breaks, and create an adequate encircling element to keep it in place. So first we go with the peritomy, then we sling all the recti, and then we localize all the breaks, prior to which we need to check the sclera to check for thinning, and then we evaluate the retina. And then we go for a retinopexy, which can be done by cryotherapy. And when we go for scleral buckling, we could go for a segmental or a circumferential version depending upon the extent of the lesion. And then we go ahead with the buckling technique, and once the buckling is in place, we drain out the SRF as well. So we need to check for buccal adequacy once the procedure is done to ensure that we do not go ahead, we do not cause any anterior ischemic effects, and we also check for perfusion of the central retinal artery. Now we go for Muhammad Ali. Once we go for Muhammad Ali, we should go for pars plana vitrectomy. So we should check for hemorrhage, we should check for multiple breaks as well. So first we deal with the pars plana vitrectomy, then we check for an endolaser, and then we go for vitreous substitutes as well. So we go for the mnemonic, that is vision, that is vitreous fraction, then we identify all the breaks, then we seal all the edges, then we create internal tamponade, we optimize positioning, and we ensure that there are no missed pathologies. So we need to see it, we need to seal it, and we need to save sight. Thank you.
Very. Oh, did I? Yeah. See, this was a most wonderful experience the last 1.5 hours to see such brilliant teachers around. I wish I had had such teachers during my time as I evolved. Then I'm sure I would have become a far, far better person than what I actually am. I did have an opportunity to be one of the judges in earlier Teachers of Tomorrow done in different parts. But honestly, what I want to convey to all of you is each of you who has participated today has evolved
into a better person, because the ability to talk with such self-confidence, and you end up reading so thoroughly about it, and there's so much of energy and charge, and in actuality there's a leadership quality which evolves in you. So if many of you are sitting in the audience, take this as a challenge and come forward and mention it to the leaders of Teachers of Tomorrow that you're interested in participating. This is a platform which you should use. Actually, I would say that Namrata Sharma, as our Chairman Scientific Committee, has ensured that there are so many platforms for all of you youngsters to evolve and grow. So make the best of it. These kind of opportunities were not there in our times. We had to have completed our whole education, or then something evolved, and it was a very step-by-step climb. For you, it's a supersonic climb if you set your mind on it. So congratulations to one and all of you for the great performance, and a very strong visual thinking and blessing to all of the others that you all should come to similar things. Thank you. Dr. Namrata, could you come here? We'll have to announce the results.
So announcing the results is okay. I'm happy I'm not the judge judging the students, because judging is more difficult, announcing is easy to do. So I think I just saw the last couple of presentations, and you people did a great job. Sometimes I feel you teach better than us also. So many things we teach you, but there are so many things, related to IT, etc., mobiles, iPads, laptops. We depend on youngsters to show us the way. So how was the experience? Very nice. Who are the first year? See, all of you are what? Senior residents, PGs? You're looking like the mentee only. Oh, you shifted to a role of mentor. So you know how to do it. So you're an experienced TOT.
Moving around the stage, presenting, using my hands, animating with them. And the same thing I told them as well. It's just, it doesn't matter what the outcome is. It's about, driving your stage fright away and gaining that confidence.
And you are first year PG?
Ma'am, I am second year postgraduate at Arvind Madurai, ma'am.
Second year postgraduate?
Yes, ma'am. Both of us, ma'am. We both are batchmates at Arvind Madurai, ma'am.
From?
Arvind Madurai, ma'am.
Arvind Madurai.
Yes.
Okay, and this team? Natasha's team.
I'm perhaps the veteran in the
Yes.
in the group here, because I've been conducting taught for KSOS for many years, and
in fact, it came from there only, I think.
No, initially from Krishna Prasad sir, but then
I
Kerala has been one of the
I saw
pioneers.
this program first time when I was made a judge in this program in Kerala by Srini.
Yeah, we've been doing it for many years now. I've been conducting it for like 3 years, and this is my second time in the All India. I brought 2 of my kids from there. They're not actually training under me, but they are from Kerala. Okay. Dr. Matthew Shaji and Dr. Eliza.
Hi ma'am, I'm a final year PG from Travancore Medical Hospital, Kollam.
Okay.
Ma'am, I'm Eliza, second year PG from Sri Gokulam Medical College, Trivandrum.
It's lovely to see how people travel, and at this age travel from far and wide. We never I think I attended my first conference, didn't do any in PG, didn't even do anything in senior residency after I finished my senior residency. But
we have a lot of opportunities because of people like you, ma'am.
But it is good, no? Because what happens is when you attend conferences, it is not about only conferencing, but your whole, your horizons, they broaden up, they widen up. You pick up so many things subconsciously which you won't realize, but when you go back, you will try to inculcate. Some things you will pick up from here, some from there. So you should always attend conferences at your level and at our level also, both the levels. And you should always, now that you have come here, done a national conference, your next aim should be to do an international conference, whether as a delegate or as a presenter. Even as a delegate, it is perfectly all right, because again, it's a totally different perspective. And when you go to an international conference, like you came here also, then it should be a conference plus program. So conference plus programs means that either you come 1 day before or 2 days before or 1 or 2 days later, visit some eminent ophthalmologist or a good center there. So you go to, say, American Academy, you go to Chicago or Orlando or whatever. So what you do is you tie up with, and nobody says no, even if you tie up on the email, just go and see how they do it. It's a different culture. So yeah, so that is what I did right from the very beginning. I always clubbed it with, 1 or 2 days before or after. Of course, you have to roam and see the place also. I'm not saying keep doing this only, but 1 day before you keep for this, or 1 day after. Normally what happens is 1 day before people won't let you in because they themselves are busy preparing for such mega conferences. But a couple of days later, you can just go visit their center. So it opens up a new perspective for you. Plus you've done some amount of networking. Plus when you go abroad, it gives you a different kind of confidence. So you should definitely do that. But anyway, now you have so many, and we have grants, travel grants. So we don't give completely, but we do support partially for US, for Asia Pacific, for Europe. So, I don't know how the pay structure in Delhi, it is very good for students. How is it, Natasha, for your state? As residents or as postgraduates, how much do they earn? They earn well? Salary. Better than most states. Yeah. And as residents, you should again make use of it. Our residents are very smart. They do it every year. As residents, as students, you get complete full grant covered by CSIR, by INSA, by which other one? DBT and DST. No, you should do it. Pranita would have attended 3 conferences through 3 different agencies in 3 years, international. So, it is like that. So you have to seek opportunities. And what somebody tells you in 1 second, you go 1,000 pages of a book, these things nobody will tell you. So I think it is my pleasure and my honor to be telling you which is the 3rd team. This is the 3rd team. So the 3rd team is the Visionaries by Dr. Shashi Agarwal. What happened? They overshot the time? They are saying they overshot. Anyway, it doesn't matter. That doesn't mean you will deny them the... Dr. Chitra will do it. Chitra will. So I would like to acknowledge, because my own teacher, Dr. Vishnu Sarup Gupta, is here. I did my first IOL with him in Safdarjung Hospital because I didn't get a senior residency in RP Center. So I got senior residency in Safdarjung, and thank you so much, sir. I will always remember that.
The second prize goes to the very smart team, Southern Stallions. A big round of applause.
Winners. Announcement. Jedi.
So the first is Jedi's. सेकंड भी होता है हो गया है ना बाकी तो यही सोच रहे थे कि जो अच्छे थे वो कहाँ गए
And for the three of you, come. Hold. Best wishes to all of you.
Okay, good. Thank you. Thank you, sir. Thank you all the judges and thank you all the mentors and the mentees. And don't get disheartened. It is just the beginning. You will be in future not what you are today, but what you become later.
See you.
Okay?